Okay, picture this. A pump that's been working nonstop, every single second, for decades. And then, all of a sudden, it's overwhelmed. It's failing. That's an acute heart failure crisis. Today, we are opening up the emergency toolkit to see exactly what clinicians use to pull a patient back from the brink when every single moment counts.
You know when a patient comes in with acute heart failure, it is a flat-out race against time. The real challenge isn't just knowing what to do, but figuring out which tool to grab first and why. It's a high-stakes clinical puzzle, and right now, we're going to piece it all together. Heart muscle is just completely overwhelmed, so our immediate goals are crystal clear. First, we've got to get rid of all that excess fluid that's causing congestion, and second, we have to ease the incredible strain on that struggling heart. Okay, so where do we start? When a patient is, and I mean this quite literally, drowning their own fluid, the absolute top priority is to get that fluid out fast. And for this, we turn to the undisputed workhorses of ADHF management, loop diuretics. So what are these things? Well, loop diuretics, you've probably heard of them, furosemide, bumetanide, they're incredibly powerful drugs with one main mission, to force the kidneys to flush out tons of excess salt and water. This makes them the absolute frontline therapy for relieving that awful congestion that makes it so hard for these patients to even breathe. Okay, the way they work is actually pretty cool. Deep inside your kidney, there's this structure called the loop of Henle, and it has this tiny molecular pump. Loop diuretics go in, find that specific pump, and they block it. What happens next? A massive amount of sodium, and the water that always follows sodium gets flushed right out of the body. This drops the total fluid volume, which means less blood is returning to the heart. We call that preload, and that gives the congested lungs a chance to finally clear out. But, and this is a big but, such a powerful effect doesn't come for free. There are risks, which is why constant monitoring is so important. Flushing out all that fluid can drop your potassium and sodium levels to dangerous lows. It can also cause your blood pressure to bottom out. And, pushing the kidneys that hard can sometimes, ironically, make their function worse. It is a constant clinical balancing act. All right, we're getting the fluid off. That's a huge step. But often, that's only half the battle. If the heart is still trying to pump against massive resistance from tight arteries, it's like trying to push open a door during a hurricane. It's just not going to work. To solve this, we bring in our next set of tools, the vasodilators. The classic tool here, the go-to, is nitroglycerin. Its main job is to relax and widen the body's veins. Now, why does that matter? Well, when the veins can hold more blood, less of it comes flooding back to the already overwhelmed heart. It's a really direct way to reduce the heart's preload, that initial stretch on the muscle before it even tries to contract. But wait, there's more. Nitroglycerin has a second trick up its sleeve. While it mostly works on the veins, if you crank up the dose, it also starts to relax the arteries. This reduces what we call afterload. That's the resistance the heart has to push against to get blood out. So it actually helps on both the incoming and the outgoing sides of the heart. Pretty clever. Now for the side effects. The main risk, not surprisingly, is dropping the blood pressure too much. That's hypotension. Headaches are also super common. And sometimes the body senses that lower pressure and it kind of freaks out, trying to compensate by making the heart beat way faster. We call that reflex tachycardia. And one last thing, if you use it for a long time, the body can get used to it and it just stops working as well. Now let's compare nitroglycerin to its more powerful cousin, nitroprusside. Think of it this way. If nitroglycerin is a targeted tool, nitroprusside is a sledgehammer. It's a balanced powerhouse. It hits both the arteries and the veins with equal force, which dramatically reduces both preload and afterload. This makes it a go-to for really severe hypertensive emergencies in the ICU, but it is not without serious risks, including crazy low blood pressure and even potential cyanide toxicity. Okay, so we've managed the fluid, we've dealt with the pressure, but what happens if the heart muscle itself is just too weak, too tired to pump effectively? This scary situation is called cardiogenic shock, and for this, we have to bring out the heavy-duty tools, the real power-ups, the inotropes. So what are inotropes? Well, in the simplest terms, they are drugs that directly increase the force of the heart's contractions. They make the heart muscle squeeze harder, period. These are not your everyday first-line drugs. They're reserved for patients who are in really bad shape, in those low-output states or full-blown cardiogenic shock, where the pump is fundamentally failing. Let's look at the two main players here. First, you've got dobutamine. It works by hitting the beta-1 receptors in the heart, basically yelling at the muscle to squeeze harder. Then you have milrinone. It uses a totally different pathway. It's a PDE3 inhibitor, but the result is the same, a stronger contraction. The key difference, though, is that milrinone also relaxes the blood vessels, which helps reduce that afterload we talked about. So think of dobutamine as a pure squeezer and milrinone as a squeezer plus a vessel relaxer. Now, these drugs are incredibly powerful, and their risks are just as serious. Forcing the heart to work that much harder can trigger dangerous, irregular heartbeats called arrhythmias. And because milrinone also relaxes vessels, it can cause severe hypotension. But here's the crucial trade-off. Both of these drugs make the heart demand more oxygen. It's like forcing someone to run a marathon when they're already exhausted. It can be life-saving, but man, it demands extreme caution. All right, let's move on to our final section, and this is just as important as knowing which tools to use. It's about knowing what else to do, and maybe more importantly, what to absolutely positively avoid. So, supportive care is absolutely key. That means giving oxygen if levels are low. It means VTE prophylaxis, that's just using meds like heparin to prevent blood clots, which is standard for anyone stuck in a hospital bed. And take a look at morphine. This used to be super common, but we now know it can suppress breathing and might even increase mortality. So its use in this kind of crisis is actually pretty rare these days. Okay, everyone, listen up because this slide is critical. These are the drugs to avoid. NSAIDs like ibuprofen, they make you retain salt and water, the exact opposite of what we want. Certain calcium channel blockers like verapamil and diltiazem, they have what's called a negative inotropic effect. That means they literally weaken the heart's pump. And look at beta blockers. While they're a cornerstone of chronic heart failure care, starting one in the middle of an acute crisis can be a total disaster because they can weaken the heart's contraction and just make everything so much worse. All right, you've seen the whole toolkit. Now let's put that knowledge to the test. Just a couple of quick clinical scenarios. You ready? Let's do it. First question. A patient comes in. They're severely fluid overloaded. Classic signs of pulmonary congestion. What is the very first tool you reach for from our toolkit? Take a second. The answer is, of course, a loop diuretic. You have got to get that excess fluid off the body immediately to relieve the congestion and help them breathe. That is always priority number one. Okay, last one. A patient is in shock. Their pump is failing hard. Why is starting a new beta blocker right at this moment a really, really bad idea? And the answer is because of their negative inotropic effect. Remember that term? It means they actively weaken the heart's contraction. When the pump is already failing, the absolute last thing you want to do is give a drug that makes it even weaker.